Welcome, everybody. This is our PEN Artificial Intelligence and Technology Collaboratory monthly webinar, also known as the PEN AI Tech webinar. And this is an initiative funded by the National Institute on Aging. Thank you so much for joining us today. Today, we're very happy to have with us Dr. Daniel Capurro as our speaker. Dr. Capurro is a senior lecturer in digital health in the School of Computing and Information Systems and Deputy Director of the Center for the Digital Transformation of Health in the Faculty of Medicine, Dentistry and Health Sciences, both at the University of Melbourne, Australia. Dr. Capurro's research focuses on clinical data analytics, including clinical process mining and health applications of machine learning, and the clinical validation of digital health innovations. Dr. Capurro co-leads the development of the Digital Health Validitron, a pipeline to test and validate digital health innovations before they're tested in clinical trials. He's also the medical director and general internist and obtained his PhD in Biomedical Informatics at the University of Washington in Seattle. Before joining the University of Melbourne, Dr. Capurro was the Chief Medical Information Officer of the Catholic University's Healthcare Network in Chile and co-director of the Chilean National Centre for Health Information Systems. We're really honored to have Dr. Capurro with us today, and also really appreciative because of the time difference. I think it's 4 a.m. his time in Australia, so we're really appreciating him joining us today. Just as a reminder, you can post any questions you have for him in the Q&A box, and after his presentation, we'll have an opportunity to have a Q&A section. So without further ado, Dr. Capurro, thank you again.
Thank you, George, so much for the invitation. It's a pleasure and an honor to be here today. It is indeed 4 a.m. And I'm hoping that some fellow Australians will also join the session, or at least watch it online through the YouTube channel. So let me share my slides. So the topic of today's session is AI and digital overdiagnosis. And first, as always, I'm going to declare my conflicts of interest. I received funding from the Australian Medical Research Future Fund. I'm in the advisory board for the National Centre for Health Information Systems, and I have editorial roles in Informatics for Health and Social Care, NPJ Digital Medicine, and the Journal of Biomedical and Informatics. And before we start, this is just a picture of the University of Melbourne. I'm the Deputy Director of the Centre for Digital Transformation of Health, a collaboration between the Faculty of Medicine and the School of Computer Science. And we're actively hiring researchers, postdocs. So if you're looking for a place to go, let me know. So what we're going to be talking about today is about digital overdiagnosis, and we're going to talk about overdiagnosis in general and its drivers, about digital overdiagnosis, trying to understand how big the problem may be, and some attempts at quantifying overdiagnosis. So as a brief starting point, we're going to start talking about overdiagnosis. And first, I wanted you to think about whether you know someone that has been diagnosed with ADHD, or whether you have been diagnosed with ADHD, just as an example to set up the scene of what we will be discussing about today. So this is a study done in Canada that shows the proportion of children receiving ADHD treatment based on their month of birth. And you can see that there's it's a progression from lower proportion to higher proportion as the year advances in terms of date of birth. And this sounds a little bit odd, but when you see what happens, when you see what happens and I just copied part of the graph and overlaid it on the right side, you can see what happens from December to January, that there's a significant drop in the proportion of children that are receiving treatment for ADHD, and these are school-aged boys and girls. And this is another study done in the USA for states that have a September 1 kindergarten entrance cutoff dates. And you can see the same phenomenon, both for diagnosis rates and medication use rates. And the previous graph was about medication use rates. So the interesting thing here is that all these children meet the diagnostic and treatment criteria for ADHD. And there's not really anything environmental, because sometimes we see, things, frequencies vary or change based on the year of the month, based on stationality. But here, there's no stationality happening here. There's just a quick drop based on the date, and it's all because of the cutoff date for school. So the only difference between the children born in January and the ones born in December is that some of them went to a different year. So they're younger in their own cohort, the ones that were born in December versus the ones that were born in January. So we're seeing children that meet the definition of the disease, but there's probably symptoms that are being driven by them just being younger in their cohort. And this leads us to the current definition of overdiagnosis. And overdiagnosis is defined as the situation of finding an abnormality that meets the agreed diagnostic criteria for a disease or a risk factor. And as we saw on the previous slides, in this case, ADHD, these children meet the definition of ADHD. So it's not a false positive, but where the disease would have not affected quality of life or life expectancy if left undiagnosed. And that's the core of the definition of overdiagnosis. So I make a diagnosis based on the accepted standard. The patient meets the diagnosis, but it would have been better not to find the disease, because finding the disease, not finding the disease would have meant that the patient would have not seen their quality of life or life expectancy affected. Another way of looking at it, and this is from the National Cancer Institute, is what happens in cancer. And cancer is another place where the problem of overdiagnosis has been extensively described. And you can see that here you have in these different color line cancers that progress at different speeds. And you have the first gray threshold here at the top. This is the size at which the cancer causes death. This first threshold here, the second gray line, size at which the cancer causes symptoms. And you can see that there's on one side, there's a cancer that grows quickly, this red line, and it quickly produces symptoms and then causes the patient's death. You have something intermediate with a yellow line, and you have slower growing cancers here with the teal and black lines. And you draw this vertical line, which is the time where you could detect disease based on screening tests. And you can see that the yellow line describes cancers for which this is beneficial. So you can see that you detect this cancer screening and you can do things before they become either symptomatic or they cause the patient's death. But for the teal one and the black one, you can see that you may be able to detect the disease earlier, but you're going to detect a disease that would have never caused the death or symptoms on this patient, either because it progressed too slowly or because it just doesn't progress. And again, these are cancers that meet the diagnostic criteria. The cells, if you do a biopsy, the cells look like the actual cancer that you're trying to diagnose. And so it's not just a false positive, there's a screening test. You verify the disease with histology. It's just that it was going to grow so slowly, or it was not going to grow. And this is where an overdiagnosis occurs, as you can see on the right side. So going back to our definition, finding an abnormality that meets the agreed diagnostic criteria. But if you would have never diagnosed the condition, it would have not affected the quality of life or life expectancy. So you can see that this definition is full of negatives, which is one of the challenges of overdiagnosis, because we don't really know what would have happened if we would have never diagnosed this. So just a couple of examples. The first one is this diagram from the New England Journal of Medicine in 2014. This is what happened in South Korea when screening rates for thyroid cancer increased. And you can see that the incidence of thyroid cancer increased almost exponentially. But when you look at what happened with mortality, it almost didn't change. So you can see that there's a huge increase, a huge excess incidence based on screening, but you're not making any impact on cancer mortality. So this is one of the hallmarks of overdiagnosis. So I start a screening program, I see lots more cases, and eventually, if the program is diagnosing correctly patients, then you should start seeing a decrease in mortality. And this is not what we saw with thyroid cancer. And this has been described in other countries as well. Another example, this is from the 1997 change in the threshold of the definition for type 2 diabetes based on blood glucose, when we went from 140 milligrams to 126. So this red strip of patients were now diagnosed with diabetes. And the issue there is that, of course, this was driven by the realization that there's an increased risk of long-term morbidity and mortality in this group, but not everyone. So in this red section of the diagram, these patients, based on the new definition, they do have diabetes. There's going to be a proportion of them that will benefit from being diagnosed, but there's going to be a proportion that's not small that will not be benefiting by being diagnosed, and you're going to label them as diabetic. And when you think about this, if you label someone as being diabetic, you can quickly realize what are the consequences of that if this patient belongs to the section of those red patients here that are not benefiting from being labeled. And if they're not being benefited, then they're still getting sort of sucked in this tract of checkups and lab tests and increased cost of their insurance and surveillance and blood glucose monitoring and so on. And when we think about going back to AI and machine learning, we usually think about, especially when we think about supervised machine learning, we think about we're using a diagnostic test, which could be a machine learning algorithm, and we compare that to the reference standard. And we normally worry about the number of false negatives and false positives. But when we think about overdiagnosis are patients that, again, meet the definition of the disease. So the label would be appropriately allocated. So these are true positives, but it's a subsection or a proportion of true positives that will not benefit from being diagnosed. So it becomes an important factor for machine learning based diagnosis. And when we think about what are the drivers of overdiagnosis, it's not because us doctors are evil and want to find patients and and find more and more patients for our hospitals and clinics. It's mostly because there's continuous attempts to find diseases earlier, and that is normally it's a good thing, but as we have been seeing, there are some downsides to finding diseases earlier in some cases, and we need to be able to get better at understanding who is benefiting and who is not benefiting. We have increasingly sensitive tests. You can think of imaging and MRIs. MRIs are another important source of overdiagnosis. Also incidental findings, widening definitions of diseases. And this could be like the case of diabetes, where we apply that to a blood glucose level, but also that can be thought from the perspective of increasing the population that we're screening, and also cultural drivers. And that's especially important in the Western countries, where usually we think that more or new is almost always better. So what does AI and machine learning have to do with that? It all starts when we start realizing that we can start diagnosing or finding patients automatically using EMR data. So, the first attempts of implementing electronic medical records, we start collecting data about patients, and then we start thinking about how can I recruit patients for my clinical trial? How can I detect undiagnosed patients? And then how can I screen for undiagnosed diseases? And usually we group all those activities in what we call digital phenotyping. And in digital phenotyping, we have a clinical diagnosis like diabetes, and then we try to find the combination of data elements stored in the EMR database that accurately characterize these patients. So in case of diabetes, it could be a combination of visits to the general practitioner, primary care, blood glucose level, combinations of ICD-10 codes, HbA1cs, medications, and so on. And again, we try to match this digital phenotype with the clinical diagnosis and try to calculate true positives, true negatives, sensitivity, and specificity. So there has been a huge emergence of decision support systems and screening algorithms that use digital phenotypes to find patients earlier. And you can quickly start realizing that that may benefit some patients that are identified appropriately, but it could be harming a section of patients that are overdiagnosed. And it's not just data coming from the health system. You can also think about data coming from other sources like patient wearables, sensors installed in homes. You can think about interactions with smartphone applications and all the digital phenotyping going on with mental health diseases, social network interactions, and so on. And most of what we're trying to do here with EMR data and these other sources of information is to find patients that are not diagnosed, so undiagnosed patients. But with the emergence of machine learning, we don't just find and classify patients as having risk of falling in the hospital, or risk of having an episode of psychosis, or finding patients with undiagnosed diabetes. But with machine learning and AI, we can now enter the realm of predicting who may have the disease even in the future. They may not meet diagnostic criteria today, but based on what the algorithms have learned from the underlying data, then they might be able to predict. And we're seeing more and more publications about algorithms that are able to predict. And we can see that prediction, again, it may be beneficial for some patients, but it may be detrimental in the form of overdiagnosis for some other patients. So right now, I've only spoken about possibilities, things that could happen with digital diagnostic tools like digital phenotyping or machine learning algorithms applied to clinical data. But So we don't have a lot of information about whether digital diagnostic tools can generate overdiagnosis. This has been understudied so far. But when we go back and contrast that to what are the drivers of overdiagnosis, and we try to think about drivers for digital overdiagnosis, we can see in these gray sentences that some of those are, they overlap what we see with traditional overdiagnosis, which has been extensively described. So again, with AI and machine learning, we're attempting to find diseases earlier, giving the vast amount of data that these algorithms can consume. They're getting more and more sensitive over time. And there's also, exacerbated cultural drivers. There's significant appetite to leverage these algorithms to actually find diseases earlier. And there's this hope and expectation that these algorithms will help us solve a lot of these problems with undiagnosed patients and detecting diseases earlier. And just some examples of publications that have been done in this area. This is a publication published in 2020, and this is a smartphone application that is using the smartphone camera and to diagnose diabetes. And again, this is not the gold standard. This patient is not getting a blood glucose measurement or an HbA1c, but this is a screening test, and a screening test will lead to then doing the actual diagnostic test, and you can see that may lead to overdiagnosis in some patients. Another example is this on the left. You see this 2017 study published in PLOS ONE, where the researchers were designing algorithms to detect Parkinson's disease earlier based on the patterns of keyboard typing. On the right hand, you can see screening for atrial fibrillation using videos, and this was published in JAMA Cardiology back in 2020. And on the next slide here, you can see this is a 2022 news article about an AI algorithm that predicts cardiac arrest up to 10 years ahead. And you can quickly see that the risk of, the algorithm is on one hand is not going to be perfect. So it's going to have some false positive, which in this case, predicting cardiac arrest with 10 years of advance may become problematic. But when you add some overdiagnosed patients, then you can see the problem emerging. And there's some unique characteristics of AI algorithms, again, especially in terms of their ability to predict what may happen in the future based on analyzing massive amounts of data. So going back to our National Cancer Institute diagram, you can see that in this timeline, we have a section of time that we call the lead time. And the lead time is the time that between the time that I'm able to detect a disease based on screening and the time where a disease becomes symptomatic or where it causes the patient's death. So that's the lead time. So time between screening and time between primarily the development of symptoms. But when and this screening happens based on normally alternative tests, but there is some degree of abnormality. When you start applying predictive algorithms, you can imagine that this line is being shifted to the left. So the lead time is probably increasing. So the proportion of patients that can be overdiagnosed can also increase. So again, when we think about this in overdiagnosis, we have the lead time, is the time between screening and clinical symptoms. But in the case of lethal or in case of overdiagnosis, I mean, the death of the patient happens before the development of the symptoms. So then the lead time tells us when the patient might be overdiagnosed. And when we add prediction there, here, what you see here on the bottom, we're moving this time earlier and earlier. So the lead time increases and the number of patients that can be overdiagnosed is probably grows. So that's one very, very specific attribute of AI algorithms that may explain a situation where we can face increased levels of overdiagnosis as we start deploying these algorithms, these predictive algorithms into clinical care. And the other aspect is that it's way easier to deploy them than other diagnostic tests. Traditionally, if somebody needs to get, let's say, prostate-specific antigen screening, they need to, go to a healthcare center, take a blood sample, wait for the results, discuss them with their doctor, and so on, and then get, if they're abnormal, then they would get a biopsy. So there's a lot of work and effort involved in screening for prostate cancer, which is one of the examples that normally gets used for cases of overdiagnosis. But in this case, this is not an AI algorithm, but it is a digital diagnostic algorithm. The study done by out of Stanford and using the Apple Watch to detect atrial fibrillation using the Apple Watch, you can see that in 8 months they were able to recruit more than 400,000 patients. But when you look at their ages, 52% were between 22 and 39 years old, which is not the age where we normally would see the bulk of morbidity and mortality associated with the complications of atrial fibrillation. So this is one example of expanding the reach of diagnostic tests. In this case, we're reaching healthier sections of the population. So that's another attribute of digital diagnostic algorithms and machine learning algorithms, that they're easier to deploy. And then, we can reach healthier sections of the population and meet one of those drivers, which is the expansion of diagnostic criteria and expansion of diagnostic abilities. There's also this problem that has been described sometimes, other studies haven't found it, is this increased trust in what the algorithm is saying. And some people call it algorithm appreciation. And the fact that some people may prefer or trust more what the algorithm is telling them than what another human might be telling them. And again, going back to machine learning, usually what we do when we train a machine learning algorithm to classify or predict the future appearance of a disease, we usually use label data. In this case, this is very, very simple table with 2 attributes and 2 labels. And based on that, the algorithm will predict whether or classify whether the patient, a new patient showed here with a new attribute 1 and 2, are case positive or negative cases. So we're using label data. Normally, what do we use to label data? Usually it's based on either expert opinions. We create a gold standard of radiologists looking at chest x-rays or CT scans, or we use data from the patient's medical record, ICD codes and other codes, or general digital phenotypes. But I would say that overwhelmingly, labels ignore the prognosis of the patient. So this is a study Google Health of the deep. I'm sorry about from the DeepMind group working on mammograms, and they did a study, a very rigorous study of AI to classify mammograms, and they did an internal validation with UK data and external validation with US data, with of course increased the robustness of their algorithm. But even with this very high impact study, we still don't know whether the patients diagnosed with breast cancer really needed to be diagnosed with breast cancer. Because when we look at traditional breast cancer screening, we can see in the late, the past 5-10 years, there has been an increase of the slow progressing breast cancers that meet the criteria, the National Cancer Institute criteria for overdiagnosis. So again, this algorithm may be very accurate in terms of separating true positives, true negatives, false positives, and false negatives, but we don't know which proportion of the true positives are overdiagnosed patients, because we don't know what's the prognosis or how these patients are going to evolve over time. So then back to our question, can digital diagnostic tools generate overdiagnosis? And the answer is probably yes, but we don't know yet. There have been very few studies trying to quantify the proportion of patients that get overdiagnosed with digital diagnostic algorithms and AI algorithms. But we know that the problem is probably going to be big. And I did a quick PubMed search on the number of publications on the application of machine learning for diagnostic purposes, and you can see that there's a massive and exponential increase in the number of publications. So there's a lot of people working on using patient data, patient-generated data, environmental signals to diagnose or predict diseases. And so we probably are going to see an increase in the number of overdiagnosed patients. And I just want to reiterate that this is not about being scared of what an algorithm may be able to do. We hope that a lot of these algorithms were going to bring a lot of benefits to patients that have less access to healthcare, that normally don't have easy access to diagnostic testing. We will be able to anticipate the appearance of very nasty diseases that are affecting the population. But we need to be aware that there's a proportion of patients that may be overdiagnosed, and we need to start thinking about those when we make our cost-benefit analysis of whether it's worth deploying a new algorithm to predict or detect diseases. So what can we do about it? First, raise awareness, and that's the main purpose of this presentation. But the second one is trying to come up with ways of quantifying it, and that's something that my research group is currently working on, and we're trying to figure out what are reasonable ways that we can use, especially when we're looking at retrospective databases. How can we quantify the risk of overdiagnosis when we deploy a new digital diagnostic algorithm or a machine learning algorithm into clinical care? So ideally, and this is how overdiagnosis was initially identified for traditional diagnostic tests, you would have the the counterfactual. And of course, we don't have the counterfactual, so we run randomized controlled trials. So when we run randomized controlled trials and we compare what happened with patients that were tested and those who were not tested, and we follow them prospectively, those who were found to have the disease, for example, in theory would receive the same treatments in both the tested and non-tested groups, and we can look at the outcome. If we're not generating any benefits, then we are likely to be facing a significant proportion of overdiagnosed patients, like the example that I showed you with thyroid cancer, where we saw an increased number of cases and no differences in mortality. But we haven't seen, there have been very few studies of randomized controlled trials of digital diagnostic algorithms with long-term follow-up and that measure patient relevant outcomes. So we're not there yet. So what we're trying to do right now in our research group is using longitudinal databases, and we started using sepsis as a use case, and we've moved on now to acute kidney failure and heparin-induced thrombocytopenia as examples of diseases that are where the gold standard is based on a set, agreed upon set of criteria. And we're using these longitudinal databases to see what would happen if we would deploy a digital diagnostic algorithm, a machine learning algorithm. What would happen to those patients when we follow them throughout the database? And we're using critical care database because these, the cases are completely resolved during the hospital admission. It's not the case that I'll admit a patient to the ICU with a case of sepsis and then send them home with an active case of sepsis that never got resolved. So that's why we're using sepsis as the use case. So what we did in our study, we took a database. In this case, it was Mimic, the critical care database out of Harvard, and we trained a machine learning algorithm to predict the future appearance of sepsis based on the sepsis 3 criteria. And we may argue for days whether sepsis 3 is the right way to diagnose sepsis, but it's the standard agreed upon criteria to diagnose sepsis for research at this time. So we have our machine learning classification, then we have our gold standard classification. So we have our true positives and true negatives. And the idea here is that we take the true positive cases and the true negative cases, and we build disease trajectories based on what happened to those patients later on. And we use some techniques from process mining to build these disease trajectories based on treatments they received, transfers throughout the hospital, whether the patient had a readmission to the ICU, whether they received antibiotics, and so on. And we use some clustering algorithms to find patients that were labeled as true positives, but based on their disease trajectories, they clustered with the true negative patients. So what we're saying here is that these are true positive patients, but they behave like they were true negative. So they don't receive antibiotics, they have similar mortalities as patients that don't have a sepsis, and so on. So we end up with clusters of patients where a majority of the cluster is a true negative, but we have some true positives sprinkled in this cluster. And based on this method, we were able to estimate that about 4.3% of the patients that were flagged by this algorithm, so of the true positives, 4.3% could be considered cases of overdiagnosis. So again, this doesn't seem like a huge number, and and the algorithm may be benefiting another section of patients. But these, 4.3% of patients, when you then take the algorithm and you deploy it in a general hospital, for example, not just in critical care patients, but for a general hospital, this percentage might probably increase, and the volume of patients might also increase. So the absolute number of patients that may be overdiagnosed can become a significant proportion. And we're now seeing that some EMR vendors in the US, here in Australia, are deploying sepsis prediction algorithms in their general hospital population. And we do not know the proportion of patients that may be overdiagnosed. Again, this is just one study using one method. We used trajectories, but there are other methods that could be used for this purpose. So it's only one study using one method and one use case. So this is a very, very preliminary research. But we need to explore different clustering methods, different conditions, and most of all, we need to prospectively validate these results. So wrapping up this presentation, the key messages that I want to give you are the following. Digital overdiagnosis, and especially using predictive AI algorithms, is highly likely. We have seen it extensively described with traditional diagnostic tests, screening tests, imaging, and so digital overdiagnosis is highly likely because it shares a lot of the drivers, and but also it has some specific attributes like the ability to predict the future appearance of diseases, and this facility, the ease with which we can deploy these algorithms to the general population or to increasingly healthier individuals is another unique attribute of digital diagnostic algorithms. Machine learning and massive collection of data are probably risk factors for digital overdiagnosis, and quantifying overdiagnosis and interdisciplinary collaboration will become essential. We need to ideally run randomized controlled trials of digital diagnostic algorithms, but we know that the speed at which these algorithms are being developed is just too fast. Our ability to run those randomized controlled trials is never going to be as fast as the speed at which we are seeing these algorithms being developed. So we need smart ways of using retrospectively collected data or large data sets like the MIMIC database to try to at least approximate the number of patients that are maybe overdiagnosed, and use that as an input to train these algorithms in a better way. So with that, I yield back to you, George, and I'm happy to take questions about this topic.
Thank you so much. Thank you for this great presentation and really thought-provoking. Just to remind our audience that you can ask your questions in the Q&A box, and we already have some. I guess I'll start with the first question. An example of overdiagnosis coming from technologies being too advanced. So CT angiograms that detect emboli that we cannot really do anything about them, and diagnosing something that then causes distress, even though there was not necessarily a point in diagnosing them. Do you think in those cases that we should consider overdiagnosis as a potential unintended consequence when we try to evaluate new diagnostic tests, that we need to think more about that segment of the population where something could be found, but it's not something that that might actually lead to worse quality of life because of that diagnosis, but cannot lead to effective treatment?
Yes, absolutely. I definitely think I strongly believe that we need to start including this into the equation of assessing whether a new technology is going to be beneficial or not for our patients, and especially I think this is this is an area where patient involvement becomes more and more important, because this the decision whether it makes sense or it produces value, it's something that we can measure based on certain outcomes, but there's also, of course, patient preferences and values that need to be accounted for. And there has been strong arguments, especially when diseases are being redefined, like lowering the threshold for diabetes or hypertension. Most of those redefinitions were done by experts, which is all good and fine, but there was very, very little to no patient involvement in those redefinitions. And we're seeing things like, based on the new diabetes definition, and they're not so new, they're almost 30 years old now, based on the new definitions of diabetes, we've seen that in studies done in China, 50% of the population meets the diagnostic criteria for diabetes, which is just mind-blowing. And of that 50%, there's going to be a subsection of that population that will not benefit, and we need to come up with methods to try to understand how big that problem is.
Great. We have a question specifically about the sepsis work you presented. What % of sepsis 3 diagnosed individuals clustered with true negatives in terms of disease trajectory? In other words, what is the rate of sepsis 3 overdiagnosis?
So in this case, it was we tested different clustering algorithms. So we got a very different numbers, but they were around the 5% rate, which we think it's an underestimation, but we tried to be very conservative in our study, and it's important to keep in mind that this was done in a critical care population, so which is already highly selected. So we can't really say that 4 to 5% is the rate of overdiagnosis of sepsis 3. If we applied that to the general hospital population, it would probably be higher. We don't know how much higher.
Another question, beginning with work by D. Dumbal, we've recognized that predictive algorithms for diseases like appendicitis might overdiagnose, and that some degree of overdiagnosis may be appropriate given the disease progression rate, the severity of damage, if the diagnosis were to be missed, and so on. Have you thought about how we could integrate that sort of thinking into predictive tools?
That's a great question, and I need to say this. So Kevin was my mentor when I was part of the JMIA student editorial board. So I need to say hi to Kevin. We only interacted through email at that time. We haven't, I think that's a great question and a great point. We haven't explored the extent to which adding that kind of information may or may not help a decision making when we deploy these diagnostic algorithms. So that's a great point.
Another question is if you could please discuss overdiagnosis and the practice of defensive medicine.
Yes, that's definitely a factor, and I must say that defensive medicine it varies a lot based on countries and healthcare systems. Some healthcare systems are more prone than others to experience this defensive medicine. But yes, when we do tests that are not necessary, clinically necessary, then and part of that is defensive medicine that can also contribute to overdiagnosis. But I would say that, and clinician and patient education is a very, very important aspect here, because I would say a lot of times not ordering a test is harder than ordering the test for various reasons. Sometimes the doctor feels like that if they don't do anything, they're not fulfilling their mission, or if a patient goes to the doctor and they don't get anything, or a test or a prescription, we're not doing anything, and that's very it generates a lot of dissonance, and so I would say that defensive medicine is definitely a factor. But the cultural aspect of going to the doctor, ordering tests, I would say it's a very, very big factor.
We have a question about the earlier example you showed about the ADHD. How was that the ADHD that was overdiagnosed detected in a school setting if there was no effect on quality of life?
Mm-hmm. Yeah, so that's a great question, because these were studies done with in the case of the U.S. study, it was done with claims and prescriptions, and of course these were patients that were if there was a claim and a prescription, somebody sought healthcare, and there was some disruption happening, or hyperactivity or attention deficit happening, but probably when a baby is born, or they're 3, 4, 5 years old, you can see that their ability to maintain focus. And again, I'm not a pediatrician, so I haven't seen pediatric patients except for my kids for the past 20 years. So take this with a grain of salt. But, attention builds up over time, as children mature, and their ability to be in a classroom and pay attention and do their activities and finish their work increases with they get better with age. So in this case, and there's a normal distribution probably around that, and in this case, these were patients that whose parents at some point thought that they were having an issue, that their doctor thought that they were having an issue, but when you apply the diagnostic criteria, there was no the age component was not sensitive enough, or there was not enough resolution to take into account how young they were in their cohort. So the level of disruption is the comparison of how much they can pay attention or complete their tasks in class compared to the rest of their cohort. And in the cohort, we have 1 full year of growth in a 5-year-old child is a huge amount of growth. And so we're probably diagnosing normal distributions or differences in the speed at which they mature as ADHD. That's probably the concept there.
I was going to ask you in terms of the overdiagnosis resulting from changing the thresholds for disease, and some arguing that we are perhaps medicalizing regular life experiences. Do you think that to what extent do you think that does lead to overdiagnosis? You mentioned some examples, but I know there's been a lot of discussions about changing thresholds for what's considered abnormal for blood pressure readings or even glucose levels. Do you think that those could contribute to the challenge of overdiagnosis?
Yes, I think there's no doubt that they do contribute. I think that when we look at diagnostic thresholds like blood pressure or blood glucose, we've seen that, and especially in older adults, there was 15 years ago there was a huge push to reduce blood levels at which hypertension was defined, and there was aggressive treatment. And at some point we started realizing that older adults especially were facing negative consequences out of that. And then the thresholds were relaxed in that population. So that's an example where we saw that. We started seeing the adverse events, and then we went back with the to less strict numbers. I think that one aspect that is very hard to is for mental health conditions. There has been new clinical conditions being defined over the years, and of course there's a lot of benefit from realizing that there are individuals that experience conditions that meet mental health criteria, but we also see, as we have seen with ADHD, and it's especially challenging when these conditions, there's no gold standard, there's no biopsy, there's nothing that tells us with certainty that this patient has diagnosis X or Y, especially in the mental health space. So I would say with biomedical variables that can be measured, it is certainly the case with diabetes and hypertension. It's probably also the case with some mental health conditions, but the challenge is way bigger there, because we don't know. There's a lot we don't know.
Great. Well, thank you again so much for this great presentation and the great discussion. I want to thank you all for attending and remind you that our next webinar will be on February 2nd. Our speaker then is Dr. Deborah Estrin from Cornell University. And again, thank you. We will be uploading the recording of today's webinar on our YouTube channel, and everybody will be receiving a notification. Daniel, thank you again.
Thank you so much, George, for the invitation, and thank you for everyone who attended.